This week we'll be talking about sexually transmitted infections. So we'll start by just doing a background of STIs, and then when we look at the infections, I think it's helpful to break it down into those that present as vaginitis, like gonorrhea, chlamydia, and trichomoniasis, and then those that present like genital lesions. You can see those below. And then we'll spend some time talking about hepatitis B as well as HIV. So when we think about epidemiology, it's important to recognize that they're extremely common worldwide. Some regions in the U.S. do have higher rates of STIs than some third world countries. Rates are highest in the southeastern United States, but in an American's lifetime, about a quarter to a half of Americans will have an STI at some point. Transmission occurs subliminally, so it's not uncommon for somebody to go undiagnosed for quite some time, and it's associated with a lot of stigma. It can be a really sensitive topic, which can make it harder to diagnose it and harder for people to seek treatment. Basically, all STIs have some form of a treatment as well as prevention strategies, and most of them have cures. And then for STIs, STI is our currently accepted term over an STD or venereal disease. And as midwives, it's important to recognize that women are more vulnerable for acquiring STIs as opposed to men based on their physiology. So, for example, with one act of intercourse, the risk for a woman getting gonorrhea is about 75% if she's having sex with somebody who has gonorrhea, whereas for men it's only 25%. So there's a larger amount of exposed mucous membranes, and certainly with that, there's also a greater risk for trauma during sex for women, which can cause breaks in the delicate vaginal lining. And the cervix, particularly the squamous-columnar junction, is most susceptible to HIV. And then the vaginal environment is more conducive to flourishing of infections compared with the penis in terms of it being a reservoir. 90% of viral and half of bacterial STIs are asymptomatic in women, which makes them more difficult to diagnose and ultimately treat. And 80% of adolescents are sexually active by 18, so younger women are at a particularly greater risk as well. They have more sexual partners, they have more of an exposed squamous-columnar junction, and greater cervical friability. So younger women even more so than older women. And then for men, they are 2 to 3 times more likely to transmit HIV than in the reverse. So confirmed risk factors. I've got confirmed risk factors, and then we also will talk about some potential risk factors. So confirmed risk factors that we know put people at a higher risk for acquiring STIs, being sexually active, obviously, particularly if they have multiple partners, abuse victims, alcohol or illicit drug use, men having sex with men, prior history of STIs in patients or partners is a confirmed risk factor for developing another one, engaging sex for drugs or money, living in an area with a high STI prevalence or incidence, healthcare workers due to needle sticks, body fluid exposure, anal sex because that tissue doesn't stretch as well, tattoos, body piercings, and then those just initiating sexual activity are also at a greater risk because it's more likely to be trauma. So potential risk factors, these have been implicated as risk factors as well. So douching, hormonal contraception, likely because it exposes more of the squamous-columnar junction, and then also potentially if people are on contraceptive pills, they may not use a condom whereas they would have before. Bacterial vaginitis, dry sex, sex during menses, and then young women with older women. And then for bacterial vaginitis, just to stress, it isn't an STI, though the change in flora and the way that it can compromise skin integrity a little bit more could put people at an increased risk, is one of the thoughts there. So I think this chart is really helpful, particularly with talking to young people who are just starting to become sexually active. So sexual exposure chart. So this says, let's see, for any of these numbers, if you've had sex with 3 people, and those 3 people have also all had sex with 3 people, then the total number of people you've been ultimately exposed to is 7. And you can see how this goes down pretty astronomically. So if you've had sex with 7 people, and those 7 people have all also had sex with 7 people, then the people you've been exposed to is ultimately 127. So you don't have to go down very far this column before this column gets really high. So I think this is a helpful chart to use when you're educating. And then screening. Who should be screened? All sexually active women. So how? History and a physical exam are first line, and then testing is as indicated. So every woman is being screened, and that you're at least asking her as part of your well woman exam. That in and of itself is a screen. So you're asking about partners, and you're asking if she feels like she's at an increased risk and would like testing, that kind of thing. So you're teaching and you're screening verbally, as well as your physical exam. And then for officially testing, the CDC recommends that all women who are less than 25 years old be screened yearly. And then obviously as people change partners and need rescreening, they would come in for that too. So first line, history and physical, and then from there, if they're less than 25, the recommendation is yearly. So special populations. In pregnancy, per the CDC, all pregnant women should be screened for gonorrhea, chlamydia, syphilis, and Hep B. And then they need to be counseled for HIV testing, and this varies by state. If they're at a high risk, then you can retest in the 3rd trimester. I think you'll find that at most of your sites, HIV is going to be done automatically for all pregnant women, but there should be counseling around that. And then if they're at an increased risk for chlamydia, you should be retesting in the 3rd trimester. So increased risk would be defined as being less than 25, new or more than one sexual partner, and then having a non-monogamous partner would all warrant retesting. STI reporting is required by all states for gonorrhea, syphilis, and HIV, and then most states will also require chlamydia. So you can look up the public health department for where you live, such as the Minnesota Department of Health, to see officially what diseases need to be reported, or infections, I should say. Okay, so let's talk about vaginitis. Vaginitis includes gonorrhea, chlamydia, and trichomoniasis. Really, if a woman is presenting with vaginitis symptoms, your differential diagnoses list should also include bacterial vaginosis as well as vaginal candidiasis. You could lump those two in too, even though they wouldn't be considered STIs, but they might present with similar symptoms. Okay, so gonorrhea and chlamydia. Our greatest risk factor is going to be age, and that would be particularly if you're less than 20. I've included details on this slide for information about the bacteria, so that's helpful when we think about treatment. And then it's worth noting that chlamydia is our most common reportable STI in the U.S., and the second most common is gonorrhea. So both of these are extremely common, but chlamydia much more so. So gonorrhea is about a quarter as common as chlamydia. So when we look at transmission, definitely sexual activity as well as inanimate objects. So they can live on inanimate objects and like thinking sex toys, that sort of thing. So that would also be a possible means for transmission. Presentation, it's primarily symptomatic. So 79% of women who have chlamydia won't have any symptoms, and about half of those with gonorrhea won't have any symptoms. So this leads to delayed and less frequent treatment for both. You might notice urethritis, so dysuria, polyuria, or noticing a discharge, dyspareunia or pain with sex. You may notice labial pain or swelling, rectal pain, and then cervicitis would also be a possibility. So I have a picture of that here on the left for the female. So you can see that her cervix is inflamed, and you see the mucopurulin exudate. That's at the cervical os here. And then her cervix looks really friable. So like if you were collecting a pap, this would probably bleed a little bit, which isn't terribly an uncommon finding. So that in and of itself isn't going to make you think chlamydia or gonorrhea, but it is going to be more friable in the case of gonorrhea and chlamydia. Less common presentations, you might see it as a pharyngitis. Gonorrhea is particularly known for that, where you see an exudate, so particularly thinking oral sex there. And then pneumonia. Chlamydia can cause pneumonia. So with the gonococcal pharyngitis, you notice like a red swollen uvula. You might see pustules on the tonsils or the soft palate. So be sure to have gonorrhea on your differential diagnosis list if people are coming in with urinary symptoms as well. So we should keep these on our radar for multiple chief complaints. Okay, so complications. The most worrisome complication we're thinking about here is pelvic inflammatory disease. So classic presentation would be a woman who's already at a higher risk for STIs. Maybe she has multiple partners, history of untreated STI, douching, less than 25, and she's got a fever and abdominal pain. So that's the most classic presentation. About an eighth of women with a history of PID have fertility issues. So associated with chlamydia would be the number one, but gonorrhea, strep, E. coli, Gardnerella vaginalis is typically BV. So you can see other diseases or bacteria can cause it, but primarily chlamydia and gonorrhea are the most responsible. And usually, well, I don't know, usually 30-40%, they actually have more than one microbe. So if you have a woman coming in with adnexal tenderness, so you've done her exam, and when you go to feel for her ovaries, that area is particularly tender, abdominal tenderness, and a positive CMT, so cervical motion tenderness, when you have her cervix between your two fingers and you kind of nudge it back and forth. We call that chandelier sign if that causes them to look like they want to hang from a chandelier. That would be worth you empirically treating for PID. So usually it develops within 7 to 10 days of menses because that cervical os is going to open up a little more. So say she has chlamydia in her vagina around the time of her menses, it's easier for chlamydia or gonorrhea to wander up into the uterus. And so then you start having symptoms about a week or so later. Let's see here. Have any other notes? It tends to be constant bilateral pain, most severe in the lower quadrants. Worse with the Valsalva, so if she bears down. She may also notice pain worsening with intercourse or just generally with movement, which is consistent with like a peritoneal pain. Teens would be at the highest risk. And then fertility issues. This is particularly an issue with PID because those fallopian tubes are so narrow, like the diameter is about the size of 2 hairs, like hairs from the top of your head. So if chlamydia or gonorrhea get up there, they can cause scarring, and then that can make it a lot harder for sperm to get up as well as the egg to get out. So increased risk for ectopic pregnancies, but also infertility in general. Okay, so then labs, there's no definitive diagnostic test for PID specifically, but if she's having these abdominal symptoms and the culture for gonorrhea chlamydia comes back positive, then that would be particularly telling. You could also consider doing a wet mount to look for BV or candidiasis, and then you could draw a CRP or a CBC as well. But again, if a woman comes in with adnexal tenderness and positive cervical motion tenderness, that's enough for you to prescribe. Okay, so how do we diagnose gonorrhea and chlamydia? So we have a few different options. You can do it basically off of a vaginal swab or a cervical swab, depending on which one you're using. It can be off of urine, so that's pretty simple, particularly for teenagers, where this might be why they're willing to be tested, to just do a urine culture. And then for PID, you'd want to use the NAT and an exam. You're assessing for abdominal tenderness, cervical motion tenderness. And then just be aware that the peritoneum can cause a lot of false positives because pain can spread all across your abdomen and it can be harder to localize it. So be thinking about appendicitis, bowel perforations, that kind of thing too. Okay, so then as far as treatment goes, gonorrhea, we're thinking of our gram-negative antibiotics. So third generation cephalosporin. Your go-to is going to be ceftriaxone, but because almost always if a woman is positive for gonorrhea, she's going to be co-infected with chlamydia, you're treating for both. So you're doing the ceftriaxone or the Rocephin for the gonorrhea, but then you're adding the zithromycin for 1 dose because that's going to be your chlamydia treatment. So if she's got gonorrhea, you're treating for chlamydia too. And then for chlamydia, we want to think about our intercellular antibiotics, so macrolides, tetracycline. Your go-to is going to be azithromycin, and then that's a 1 gram dose. So here you can see if she's got gonorrhea and chlamydia, we've got azithromycin for 1 gram, and that's our chlamydia, plus the ceftriaxone as a shot, and that's going to be our gonorrhea treatment. And then if you think she's got PID, you're doing the ceftriaxone to cover gonorrhea, and then generally instead of doing the 1 dose treatment for chlamydia, you're going to do doxycycline for 2 weeks instead, which is the alternative. So azithromycin for 1 dose 1 time versus doxycycline for 2 weeks. And you could also consider adding Flagyl for 2 weeks if you suspect PID as well. So if a woman tests positive for gonorrhea or chlamydia, you do not need to do a test of cure unless she continues to have persistent symptoms, you're suspecting a reinfection, she's pregnant. So if a woman is diagnosed as positive in pregnancy 3 weeks after treatment, and then again 3 to 4 months after treatment, you should ensure that she's still not positive. Or if you suspect questionable med compliance, then that would be worth doing a test of cure as well. So you're going to want to rescreen for infection, and that's not a test of cure. So for rescreening, this isn't wondering if your treatment worked, this is wondering if she got it again. So if you treat a woman's chlamydia and her partner doesn't do his treatment, then she's just going to get it again, right? So it's not a test of cure, but you are going to rescreen in 3 to 4 months after treatment for everybody. The test of cure has a fairly high false positive rate if you do it within the first 2 weeks. So that's why you typically, if you're going to do a test of cure, you're going to wait 3 weeks. Otherwise, it may just say she's positive even though she's not, because it's still in her system. All right, so trichomoniasis. It's an anaerobic flagellated protozoa. You can see these here, especially on wet preps, you can see them swimming because they've got these flagella that stick out the end and that propel them across your slide. It's transmitted skin to skin or through sexual intercourse, and it's the most common pathogenic protozoan in developed countries. So 50 to 85% are asymptomatic. You're seeing a trend there. But if she does have symptoms similar to our other vaginitis infections like gonorrhea, chlamydia, you might notice dysuria, vaginal burning, pain or itching, vaginal discharge, and trich's a little bit unique here. So characteristically, it's a green, yellow, or gray, foamy, along with possibly a fishy odor. So I kind of think frothy, which this picture doesn't demonstrate. Potentially pain with sex, and then the classic strawberry cervix. So this is what this picture is demonstrating. You can see how it kind of looks speckled. That's classic for trich. You can sometimes see it with other forms of vaginitis too, but especially trich. So diagnosis, it could be on a wet mount. That's quick, very specific, but somewhat poor sensitivity. But if you're seeing moving, i.e. live, trichomonas, then that in and of itself is enough to diagnose it. You could also do a NAT. Though it's a little bit more expensive, but it's got a high sensitivity and specificity. Or you could do a culture, which is considered the gold standard. But it can take a little bit longer. Okay, so treatment is Flagyl or metronidazole. It's a 2 gram dose that you take 1 time. I think any of these STI treatments, if one of your options is something they just have to take once, they're way more likely to be compliant with it, right? So that's a positive. And then anytime you're giving out Flagyl, advice not to take alcohol for the next 24 hours. And then an alternative would be tinidazole. And then make sure that we're treating partners, even if they're asymptomatic. For pregnancy, trichomoniasis is associated with preterm delivery, and a low birth weight. So we want to be treating it the same. So we're not going to use tinidazole, but Flagyl is fine for pregnancy. And then if they're breastfeeding, that would be worth pumping and dumping for 24 hours after treatment. Okay, genital lesions. So we're going to talk about HSV, syphilis, human papillomavirus, chancroids, and molluscum contagiosum. So for the herpes simplex virus, as a reminder, the herpes family has quite a bit in here that wouldn't be considered an STI, so mono, chickenpox, but specifically here we're going to be talking about HSV1 and HSV2. So HSV1 and HSV2 like warm, moist locations, so particularly the mouth and the genitalia. HSV1 tends to prefer the mouth for oral lesions, whereas HSV2 tends to prefer genitalia, but you can find either one in either place. HSV1 is really common, so about half the population would be considered positive if we drew serum labs to look for it, whereas about 16% of the population would be positive for HSV2. About 2/3 of people that are positive are unaware, so they potentially have never had an outbreak. This is going to be transmitted via physical contact. And then screening in the general population isn't recommended. And part of that is just because you can see how high it is that people are positive. So it matters more if somebody's coming in symptomatic. We're not just routinely screening for it. And this is considered the gift that keeps on giving because it persists for life. We can't cure it. And there's constant shedding. So certainly higher levels of HSV would be shedding if people had an active lesion, but whether they have an active lesion or not, they're always shedding a little bit. Okay, so HSV, manifestations. You might see it in the mouth, so gums or lips. Here's an example of just under the lip. Genitalia, you can see all through here, ouch. Fingers could also have it, that's common in dentists. Face, ears, neck, brain, and esophagus. So you can see it in a lot of places, but in this case, as a midwife, you'll primarily be treating it in the context of oral lesions or genital lesions. And because HSV1 and HSV2 are happy to be in either locations, oral sex is something that we need to be counseling our patients about because she could have an oral lesion and then cause her partner to have a genital lesion. So that's important to keep in mind that both are happy in both places. Extremely painful vesicular lesion. So you can see these are vesicles. They're little clusters of fluid-filled pockets here, and they're painful, and that's going to be one of the primary ways you'll distinguish it from other types of lesions that a woman might come in with. So again, we're in the category here of lesions. So when we find genital lesions, and in this case, herpes is standing out because it's painful. So how do we diagnose this? Usually it's clinical. Again, this is a painful lesion. She might notice itching, dysuria, fever, myalgia. All of these would be consistent with herpes. Here's an example of how you might chart it on a physical exam. Cluster of fluid-filled, well-circumscribed, largely discrete, tender, less than 1 centimeter lesions with an erythematous base, without active exudate or crusting, which you might find if it's further along. So this would be kind of a fresh outbreak. Most consistent with vesicular lesions, inguinal adenopathy bilaterally. So that could be an example of how you chart it. You could also culture it, that's preferred, or perform another test, a microscopy test, if the diagnosis is equivocal and the lesion is active. So here's what's tricky about this though. If you've got a really juicy cluster, you may very well be able to get a culture off of it, but if there's not much fluid anymore, it could very well be that it's herpes, but you're not able to get a positive read off of your culture. So if it's starting to crust over, that kind of thing, then it's going to be hard for you to get a good sample. So again, sensitivity is low in both tests, but the specificity is high. So if it says that she's got it, she's got it. Whereas if it doesn't say she has it, she could still have it. So I think it's worth counseling patients too about prodromal symptoms. So before an outbreak actually occurs, she may feel burning, itching, or tingling near where the virus first entered her body. She may also feel pain in her lower buttocks, thighs, back, or even knees. So those are called prodromal symptoms. A few hours later, she might notice the sores start to appear. Incubation period is about 2 to 12 days. So it can range. So treatment, acyclovir, valcyclovir, famciclovir. So dosing and duration is going to depend on whether the presentation is initial, so the first time she's had an outbreak, a recurrent outbreak, or if she's getting them so often that we're going to do suppressive therapy to keep it at bay. So patient teaching, we want to make sure that we're discussing the risk of HSV with pregnancy to women of childbearing age. So that's really important because babies can get really, really sick if they're exposed to it on the way out. So 36 weeks on in pregnancy, we'll prescribe suppressive therapy, and they'll just be taking it every day to make sure that we don't have an outbreak. So if she's got a history of a genital outbreak, then she's taking it towards the end of her pregnancy up until the birth to ensure that there's not an outbreak. Tips, things that can help because they're really painful, right? Sitz baths with baking soda can be helpful. Like if she works out, not letting her kind of sit in the sweat, but take a shower, use a hair dryer, dry that area off. White cotton underwear, anytime anybody's having any kind of recurrent or chronic vaginitis issues, but especially HSV, white cotton underwear is the way to go for just it being breathable. Tea bags or clove compresses can be helpful. Oatmeal baths, and then diets high in vitamin C, B-complex, zinc, calcium, kelp powder, sunflower seed oil, lysine, liquid burdock, and calendula are all good ideas too. You can see some of those she could be taking in supplement form. Some of them might be like an herbal bath she could sit in. So there's multiple ways to go about intaking those. Some of those are just about having it be high in your food. And then PO analgesics can help with discomfort and then discourage ointments. Alright, syphilis. So syphilis is a spirochete, and it's considered the great imitator in that symptoms can vary a ton. You can have constitutional symptoms, respiratory symptoms, GI, skin, so it can be kind of hard to find it and figure out that that's what's going on. Co-infection with HIV is extremely common, and it's transmitted sexually as well as vertically, meaning from mother to baby in utero. Part of why that's on our list for screening everyone in pregnancy. Okay, so syphilis. This is absolutely, all of this is stuff you'll need to commit to memory, but this especially is definitely board's territory. So there's primary syphilis, secondary, tertiary, and latent. So primary syphilis is a chancre. So here's an example of a chancre. It's a painless, ulcerated lesion that she'd find on the genitalia. So that would be our first sign that we might have syphilis. It could also be on the cervix, perianal area, or the mouth. So that's our first indication that we have primary syphilis. So you might not diagnose this till we're further down the line, and then you could ask her, did you ever notice kind of a funky bump a while back that didn't hurt, that showed up and then went away? It starts out as a painless chancre, and then it degrades to a painless ulcer. So then secondary syphilis is a diffuse rash that includes the palms and the soles. You can see hands and feet here, but it can be all over the body. So this is all secondary syphilis. There's symmetrical maculopapular rash that you'd find on the palms and soles, and then there's generalized lymphadenopathy as well. She may even notice a possible fever, headache, or malaise at this point for secondary syphilis. And if she doesn't get treatment, then it'll probably just go to latent phase, which basically latent phase means that there's seroreactivity, so we can find it if we draw labs, but she's not having any symptoms, so no clinical evidence of the disease. So we'll get primary, then secondary, and then we go into kind of a latent zone. For about a third of women, if left untreated, they'll go on to develop tertiary syphilis. So it's not a given that tertiary syphilis would show up, but in this case we might have skeletal complaints like arthritis or myalgia, neuro complaints with neurosyphilis, could include irritability, headache, balance impairment, memory loss, tremors, so really broad. Of note, neurosyphilis, we think about it in the context of tertiary syphilis, but really neurosyphilis could happen at any point. Primary, secondary, tertiary. So neurosyphilis is a possibility at any point. Okay, so Again, you can see these are just really generalized complaints that can be kind of hard or tricky to diagnose, which is why this primary and secondary syphilis, that's a little bit more obvious. So if you suspect it, to be going back and asking about her past history is important. Okay, so how do we diagnose it? The initial test, which has a high sensitivity but a poor specificity, would be an RPR or VDRL, but there's a fair number of false positives. So if she has a viral infection like mono or hepatitis, then that could show up as a false positive. And I see I have a little mnemonic here. So VDRL, viral infection, drug reaction, rheumatic fever, lupus, or leprosy, all of those could cause false positives, which is why it's considered to have a poor specificity. Secondary tests, whereas a high sensitivity would mean if she doesn't have it, and says she doesn't have it, she really probably doesn't have it. So as far as the difference between these two, RPR is looking for nonspecific antibodies, so seroconversion typically takes 6 to 8 weeks. So if it comes back as negative, consider retesting in a month or two. Whereas VDRL uses an antigen that an antibody in someone with syphilis would bind to. So that's VDRL there. Okay, so the initial testing then, both the RPR and the VDRL, those are non-treponemal tests, whereas secondary testing would be considered our treponemal test. So that's a better specificity. So this is kind of like our confirmation. So if this part is showing up as high, then we're going to confirm it with this part. And then this is an example of that dark field microscopy, where they would see it. And then neurosyphilis, a lumbar puncture could diagnose it as well. You can presumptively treat with 2 tests, and then the definitive diagnosis for treatment would be that dark field exam plus the direct fluorescent antibody test of the exudate. So you can presumptively diagnose and treat, though, with the 2 tests. Okay, so management, primary and secondary syphilis both, you'd be doing penicillin G, IM, 2.4 million units, and that's 1 shot. Caveat, if the duration of the infection has been more than 12 months or you don't know when it started, so we're not sure when that first chancre developed, then you can do 2.4 million units 1 time, once a week for 3 weeks. So they'll get the 2.4 million dose 3 times ultimately. So if it's primary or secondary syphilis and it's been less than a month, it's just that 1 shot and we're done. Tertiary syphilis, you would do basically the same as this one. So if it's been more than 12 months, or if it's tertiary syphilis, we're doing the shot once a week for 3 weeks. And then lastly, if she does develop neurosyphilis, we're switching from penicillin G to aqueous crystalline penicillin G, and that's going to be IV. And so that would be an inpatient situation if she develops neurosyphilis, which again, neurosyphilis could happen at any point. Okay, so non-treponemal titers. So for management, we have to know how to manage our titers here. So non-treponemal titers correlate with disease activity. So a high titer is considered greater than 1 to 16 and indicates active disease. Whereas we need to see a 4-fold change, and I would highlight that if you've got this printed out. That's boards worthy right there. 4-fold change, i.e. 2 dilutions, indicates that there's been treatment effectiveness. So you draw on your non-treponemal titers, the RPR and the VDRL, and then you treat. And then if we initially saw 1 in 16th, 1 in 4 after treatment, would mean that we successfully treated. If there's a 4-fold increase, we need to consider a relapse or a reinfection. Again, we want to think about partner treatment here as well. And then you want to draw non-treponemal serologic titers at 6, 12, and 24 months following treatment. So you've treated her with, say it's primary or secondary syphilis. You've treated her with the 1 shot, 1 time, done. And then we're going to draw our non-treponemal tests again at 6, 12, and 24 months. And we should see that we've had a 4-fold change. So 1/16 initially, 1 to 4 after treatment. Anybody who test positive for HIV should also be tested for syphilis because the chances of her having both are fairly high. And then it's important that we watch out for a GH reaction after treatment. So basically, I think of this like bacteria blowing up from therapy. It happens within 24 hours. If it happens after 24 hours, consider something else, like a penicillin reaction. But if it happens within 24 hours, then that would be something to be watching for. So more common with earlier stages of syphilis, and it looks like sepsis. So acute febrile headache, malaise, etc. Okay, so HPV, we've talked about a fair bit already as it relates to cervical cancer, but remember HPV is responsible for both genital warts as well as cervical cancer. This would actually be considered the most common STI in the U.S., so chlamydia for reportable infections, but just across the board, HPV is the most common STI, and it's transmitted via physical contact, which I think is important in our teaching because you don't have to have sex in order to get HPV. It can just be physical contact. So at least 50% of people will acquire it at some point in their lives, and the rate is the same for women who have sex with women. So at some point, about half of women are going to have HPV. So again, just as a refresher, there's 100 types of HPV out there. If you have a wart on your finger, that counts. So 70% don't affect the genitalia. 70 types don't affect the genitalia, whereas about 30% do. And then of the 30% that do, we can divide them into the high-risk types, such as 16 and 18. There are others, but those are the most common. And that's what we worry about for causing changes to our cervix that could ultimately lead to cancer. And then there's our low-risk types, 6 and 11 being the most common ones there. So a total of 30 types, but 16 and 18 cause the most cervical change, 6 and 11 cause the most genital warts, chronolomata, acuminata. Okay, so 16 and 18, that's 75% of the high-risk types, and then 6 and 11 account for 90% of the low-risk types. So that gives you kind of a sense of how common those ones are. Okay, so HPV, generally asymptomatic. So again, this is somebody showing up with a bump where it doesn't hurt at all. She's just seen it. So here's an example of how you could chart it. So this one's on a penis. These ones look like they're both on female genitalia. You could chart it as a sessile, flesh-colored, non-tender, non-erythematous, non-exudative, less than 1 centimeter lesion, which it could be bigger than that. I think of them kind of like cauliflower clumps. And sometimes they'll even have a stalk like broccoli or cauliflower too. Potential symptoms, she might have some vaginal bleeding, especially after sexual intercourse. She might have some pain with sex with it. Sometimes irregular menstruation. Red flag symptoms, thinking again, some of this is getting into the warts and some of this is getting into cervical change. But red flags would be weight loss or fatigue, because we're thinking cervical cancer here. Having a big mass, pelvic or back pain. Things to think about. So HPV, we can screen starting at age 30, right, where it's done routinely. And then for diagnosis, generally it's clinically diagnosed for genital warts, so you see it and you call it as it is, whereas for the high-risk types, that would be found with your pap smear. So cytologically versus clinically. Treatment. So high risk, obviously we're following our ASCCP guidelines to manage PAPs with positive HPV results. But for this presentation, we'll talk more about our genital warts. So low risk, 20 to 30% will resolve spontaneously. So you could choose to do nothing. That would be an okay treatment option. Or chemically, you could prescribe one of these, they're like ointments that she could apply. And then surgically, you can basically freeze them off to a few different options there. And I used to do some cryoablation. So depending on your site, this could definitely be something that you're doing too as a midwife. Prevention, we've got vaccines that are approved for women and men up to 26 years. So Gardasil is going to cover 16, 18, 6, and 11. So 75% of those that cause cervical cancer, 90% of those that cause warts, and then Cervarix is just covering the ones responsible for cervical cancer, so it wouldn't prevent warts. Okay, so moving right along, we're on to chancroids. So these are caused by a bacteria. They're more common in Asia, Africa, and South America, but outbreaks do occur in the U.S., so worth mentioning, and then not all of us may be practicing in the U.S. for our full careers, so worth mentioning for that reason too. Transmission is mainly sexual contact, particularly if there's trauma involved with it too. And the incubation period is about 4 to 7 days, max of 3 weeks. It looks almost exactly like the chancre that we think about for syphilis. However, this one's painful. So far, if we add them up, HSV is painful and this chancroid is painful. So those lesions would look pretty different, right? The little vesicles versus a chancroid. So symptoms, painful skin lesion on genitalia, and it tends to start out as a macule, and then that develops into a pustule, that develops into an ulcer, and then you may even notice the bubo, and that would be over like an inguinal lymph node. So this is an enlarged inguinal lymph node. Generally, 1 to 2 weeks, the skin over the node starts to become erythematous, and then the center can start necrosing, and the node will ulcerate. So far down the line, this is what you might see. And initially, this is what you might see, so pretty painful. So diagnosing it would be clinical, so this is you finding it. So you're finding the painful genitalia ulcer, a painful genital ulcer with no evidence of HSV or syphilis. So if this is what you're finding, you can rule it out if it's not HSV or syphilis. And then lab-wise, you can try culturing it, but you need to have a specific medium, so that may not always be available depending on where you're working. In management, important to test for other things too, especially because oftentimes if you've got one STI, you may very well have multiple, and then you're going to treat it with a macrolide, or a third-generation cephalosporin, or a fluoroquinolone, and ulcers can take up to 2 weeks to heal. All right, molluscum contagiosum. So this is caused by the pox virus. It's extremely contagious via physical contact, so it's not necessarily sexual contact. Presentation, it starts as a small painless papule, and it's got a little central dimple. So it's small, it's painless, and then you can see how there's like a little dome inside each one of them, kind of like a little dip. You can biopsy, but it really isn't necessary to diagnose it. These cause no threat to life, but they can leave scars or be persistent and lead to secondary skin infections. So you can kind of decide whether or not you want to treat. And then you should also consider herpes on your differential. So herpes is going to be painful, right? So that's your biggest difference there. You can see the colors too, like the little clear white vesicles of herpes or HSV versus these being pinker more flesh colored, and then they've got that little dimple. So you can manage with observation, like I said. You don't necessarily need to treat, or you could try the imiquimod. And you could also do surgery, but if we're trying to prevent scarring, then that doesn't necessarily feel like a great option. All right, hepatitis B. So we're switching gears here. We're done with vaginitis, we're done with lesions, and now we're going to talk about hepatitis B and then HIV, and then we're done. If you need to take a break as you need to. I know this is a long lecture. So hepatitis B causes about 80% of liver cancers around the world. Risk factors include immigrants and refugees from areas that have a high prevalence of hepatitis B, as well as babies born to high-risk individuals. And then Hep C and HIV-infected individuals are at a greater risk for having Hep B as well. This is extremely infectious. It's 50 to 100 times more infectious than HIV, and the rate of conversion to acute or chronic depends on the age of the infection. So if newborns or infants are exposed and develop Hep B, there's a 90% chance that it could develop into chronic hepatitis B. Whereas the older you get, the less likely it will be that it will develop into chronic hepatitis B. So this is why that Hep B vaccine starts at birth, because if a mother has hepatitis B and her newborn is immediately given the hepatitis B vaccine, lower chance that this baby's going to develop chronic hepatitis B for life. Our most common method of transmission in developed regions, it's generally IV drug use, and in developing regions, it's generally vertical transmission, so mama to baby. All right. So these are the lab testings associated with hepatitis B, and this is definitely a page worth committing to memory and the sorts of questions I can see boards questions coming off of too. So if she's positive for the Hep B surface antigen, that means she has the infection. So we're finding that the antigen is in her body. If she has the anti-HBs or the Hep B surface antibody, then that means she's immune, and that could either be because she got the vaccine or because she's had a prior infection now she's been able to make antibodies. Okay? And then for the total Hep C core antibody, that means she either has a previous or an ongoing infection. So this means I've actually found, so the core antibody means she's actually been exposed versus the surface antibody could just be from a vaccine. And this could mean that she's currently fighting it or that it's antibodies in her system remembering from having fought it before. Okay? And then last one here, the IgM antibody to Hep C core antigen means she has a current infection or the infection was in the last 6 months. So this is all worth memorizing. Okay, just commit it to memory. Okay, so Hep B is going to look different depending on staging the disease. So acute hepatitis, clinically, that could look like acute illness with one or more of the following symptoms. So fever, headache, malaise, anorexia, nausea, vomiting, diarrhea, abdominal pain and jaundice, or elevated ALTs. Labs, again, that the HSV-SAG is positive, as well as the anti-HBC IgM is positive. So that's acute hepatitis. So chronic hepatitis, or carrier status, clinically, you don't have to have symptoms. You could be asymptomatic. And in labs, you're going to have 2 positive tests of any combination of the following. And this is per CDC and NIH case definitions. And then lastly, treatment for most cases, as a midwife, you're just going to refer. But for Hep B positive mothers, whether that's acute or chronic, who just had a baby, we want to treat the baby with the hepatitis B vaccine and the hepatitis B immunoglobulin. And then if the mother has an acute hepatitis infection, you're referring. But this would be the part that would be most pertinent for you as a nurse midwife. If the mom is Hep B positive, baby needs both of these things at the birth in order to prevent that baby from developing chronic hepatitis. Great. Oh, and I've got some stats for us here. So giving the baby the hepatitis B vaccine decreases that transmission rate to about 50%, whereas it would have been about 90%. And then by giving the hepatitis B immunoglobulin, it decreases the transmission risk to less than 1. So the vaccine makes a huge difference, and then adding the immunoglobulin too brings it down to less than 1%. Okay, HIV. So it's a retrovirus, considered currently a global pandemic. Mechanism of infection is by infecting the CD4 T cells, and then it can be transmitted sexually, vertically, mom to baby, or otherwise sharing of bodily fluids. So IV drug use, for example. HIV symptoms, generally asymptomatic, but can have a flu-like illness. As CD4 counts drop, more serious manifestations occur. So these are infections that basically are common if somebody doesn't have a great immune system. So unless somebody's immune system is particularly infected, all of these infections here are pretty strange to see. So that's what's going to make us think HIV. So AIDS then, so you can be HIV positive, but then to have AIDS means any one of 27 AIDS-defining diagnoses plus a CD4 count of less than 14% of the total lymphocytes. So screening, everyone 13 to 64 should be tested at least once, and then annually for those with additional risk factors. And then to diagnose it, we've got 2 options here. So we've got the rapid HIV antibody assay, that's the ELISA, that has a high sensitivity and a poor specificity. And then we have the Western blot, which is our higher specificity. So this is your initial test, and this is your confirmation test. That's another one I see on boards questions quite a bit. Really, this whole lecture has a lot that's going to be linked with boards. So I know it's long, but worth committing to memory. Antibodies can be detected in 95% of infected persons within 3 months of the infection. So that's for that initial test with the ELISA. So ELISA, and then Western blot is our confirmation. Management, pre-exposure prophylaxis. So daily medication for life to reduce risk of HIV transmission. So think of this as like maybe somebody who is married to somebody who's HIV positive and they're thinking about getting pregnant. This would be an option. Or maybe it's like an IV drug user, or maybe it's somebody who works as a sex worker, that kind of thing. If they're potentially being regularly exposed, this would be a way to reduce the chances of them developing HIV or becoming HIV positive. So that's one option, is pre-exposure treatment. And then there's treatment if they're positive, right? So that involves, for management, obtaining regular CD4 counts and HIV viral loads, and then exploring heart therapy. And then for suspected exposure, it's initiating PrEP as well, so the pre-exposure prophylaxis. And then you're checking HIV at 6 weeks, 12 weeks, and 6 months. So maybe that's a needle stick where you knew that person was HIV positive, or if somebody comes and says, I had unprotected sex and just found out he's HIV positive, then you could initiate the PrEP for that as well. Okay, one of the most sincere forms of respect is actually listening to what another has to say. So I think it's really important that we respect our moms and that we come alongside them and instilling in them respect for themselves. Be that provider they can open up with about anything. Come into the conversation without preconceived judgment, and you'll gain her respect and her trust. Meet her right where she is, and that's where she can receive love and care. So this is really a ton. How should you go about studying STIs? So first of all, it's really straightforward. This isn't hard content to understand, but it's a lot of memorizing and a commitment to stay current once you're in practice. So you can be thinking about risk factors. I would just make yourself a grid and write all these down and fill it in for all these STIs. So what are the risk factors? What are the causes? Is this a virus, a bacteria, what kind? Protozoa. Presenting symptoms. So what would you expect to see for a woman coming in with an STI? Specific complaints. What should your physical exam include? Differentials. So what else might present like this, and how would you tell it apart? So I initially broke it down into vaginitis and then lesions. So then between those, how would you differentiate one from the other? Is it simply doing a lab test? Is it noting if it's painful or not? And what does it look like? So in your grid, when you put it together, you could have a little picture too, if that helps. Okay, so then diagnosing it, what specific lab tests, if any, would you need to be done? Would you do a culture, an ELISA? Is there an initial test and then a confirmatory test, like the Western blot for HIV, that sort of thing? For management, can we cure it, or are we managing it? Treatment. You don't need to memorize every alternative, but you should know at least the main recommended first-line med for dosing. And CDC is going to be your go-to there. Okay, and then think of drug families and the patho behind it too, and that can help you kind of understand treatment better as well. So for sequela, things like Hep B can lead to liver cancer or cirrhosis. Gonorrhea or chlamydia could lead to PID. So be thinking about potential sequela. And then for patient education, you want to think about transmission, prevention, prevalence rates, anticipatory guidance, like how often they may get herpes lesions, that kind of thing. All right, happy studying, everyone.